Alright guys, in this video we're going to begin with pathologies of our GI system. I'm going to try to stay in order and go from ascending to descending, but I may jump around here and there. As long as I get the point across, I hope that doesn't get me off track. We're going to start off with a couple of the diseases from the esophagus. There may be a couple more that I'll leave out, but I'm going to go over the most common and the most dangerous. I want to start off first with GERD, gastroesophageal reflux disease. GERD can be caused by a lot of things. You know, it can be because of weight gain. It could be because of a hiatal hernia. Now, a hiatal hernia would be, there are two types. There's the type where it slides up and down, the junction of the esophagus and the stomach right over here, right before the fundus. They tend to slide up and down. Okay, remember there's some connective tissue around here, right? We have the inferior vena cava and the phrenic nerve over here. Then we have some more connective tissue, which is actually the largest hole that we have, and that's for our esophagus to connect with our stomach. And then a little bit more posterior and inferior, we're gonna have the aorta and lymphatic that comes from our abdominals and everywhere in the lower portion of our body into the thoracic cavity. What happens with a hiatal hernia is you obviously have sliding of some of the stomach up into this area. So remember that this sphincter right here is a sphincter based on pressures. Okay, if it's loose and it's moving around, there's going to be an inconsistency in how much pressure there is. The stomach, when it's empty, has less pressure and it's flatter, and there's more pressure up here, which keeps contents from the stomach down. Okay, negative pressure, positive pressure. When this moves around and it opens up a little bit, some air, little by little, remember I said how we swallowed air, gets trapped in the stomach and can build up pressure. Now imagine when you eat. When you eat, you also have a buildup of pressure. So you have all this buildup of pressure and you have a sliding junction, right, which is supposed to keep the homeostasis of the physics, right, the homeostasis of the physical particles inside of your stomach. It's not working, right? So the pressures aren't working the way that they should be, and now the pressure building up in the stomach from air and digested food is going to go up against the sphincter. Since the sphincter is not working properly, some food will regurgitate and you get a backwash, you get a pain in your esophagus. Now I want to bring up one point. Remember that the vagus nerve up here, I drew it in green, it does stimulate our cardiac tissue. Okay, it does stimulate our cardiac tissue, and it also does stimulate our esophagus and the rest of our GI. Right here is the pericardium on the outside. It goes through. It also slows down the SA node for cardiac conduction, and it can be mistaken as a heart attack sometimes. A lot of individuals will tell you I have this burning pain or this nice stabbing pain that radiates to my back. You're thinking, oh my God, aortic aneurysm or aortic dissection. Yes, you should always have that in mind. If you don't find an aortic dissection and you don't find an aneurysm, remember that the esophagus can also present like that, okay? It's very hard to tell what it is. Hopefully with a lot of patients, they can tell you they had some backwash, and when they lay down, symptoms get worse. When they sit up, symptoms get better. But at the end of the day, sometimes people give you very vague and not too much detailed description of their pain, and it can mimic, in those cases where the patient cannot draw a picture for you, it can mimic a heart attack, and it can mimic an aortic dissection or a pulmonary embolism. So you have to be very, very careful, okay, not to always discard a chest pain, because the way that they describe it to you, oh, you know what, it's just esophageal reflux. It could be a majority of things, okay? It could be a vast amount of things going on here in this area. So just remember that a GERD can present with pain very similar to a heart attack, aortic dissection, or pulmonary embolism. Okay, it can cause shortness of breath sometimes. Okay, and it's not necessarily a physiological thing, it's more of a psychological thing. When patients do feel bad and feel the stabbing pain, they feel that they have to catch their breath, and by breathing in deep, patients tend to increase their pressure in their thoracic cavity, and that increase in pressure in the thoracic cavity tends to put a little bit of pressure on the esophagus, and it helps somewhat hold things down a little bit. So sometimes patients will breathe in deep and try to breathe in as a COPD patient with their lungs filled as much as they can, because it increases the pressure and reduces the symptoms of reflux a little bit. It's not necessarily going to work a lot, but from time to time it could alleviate them a little bit. So they may tell you, listen, I'm also short of breath. So sometimes the picture is not 100% clear. Make sure that you're not right away convinced that it's one diagnosis, and make sure that you cross out all the criteria before you diagnose this patient without doing the proper test, right? A way to diagnose esophageal reflux disease is mostly by history and in the outpatient setting. If a patient does come to you complaining of this, usually happen every time that he eats, about 10, 15 to 20, 30 minutes after he eats, and it gets better after a while. It gets worse when he lays down. He doesn't have any shortness of breath. You rule out heart disease or any pathology with the heart. You rule out that he has any coagulation problems or aortic dissection. You feel, hey, this is presenting like a real esophageal reflux disease. So what you're gonna do, if it's pretty if it's a new onset and the patient doesn't have a long-standing history of this, you are going to, in this case, prescribe them H2 or proton pump inhibitors. Okay, proton pump inhibitors will work on the parietal cells, blocking the mechanism that leads to hydrochloric excretion from the cell. And the H2s are going to work by blocking other stimulants to the parietal cell. All right, they're going to block, I believe it's the G cell, and they're going to decrease the amount of gastrin that's released, which gastrin in turn also promotes hydrochloric acid. So PPIs and H2s can work. Antacids can work acutely. In my opinion, I personally had reflux for about a month or two, and I took PPIs for about a month, and everything got better. I improved my diet, and I avoided stress a little bit, and I haven't had to take PPIs ever since. But for me, the best thing has been PPIs, so I don't have to worry too much about it until I put my diet and my lifestyle a little bit in better order. So that is basically GERD in a nutshell. If you have a patient with GERD for a long-standing period of time, in other words, they've had it for 8, 9, 10 months, a year, as long as they can remember, it's been getting worse recently, yes, you will start them on H2 blockers, and you will start them on proton pump inhibitors. But you may also want to do something called a Bravo monitor, or some other type of monitor that may be out there. And you basically actually clip a microchip or a sensor right around this area, right in the esophagus. Some type of the gastroenterologist will do this, but somewhere above the esophageal sphincter, and it records how much reflux the patient has over a period of about 48 hours. After 48 hours, this microchip is basically released from the lumen of the esophagus. Remember, your GI sheds a lot of cells, all right? And these little microchips are just thrown down through the GI, and like a capsule endoscopy or a capsule colonoscopy, it just comes out and you excrete it in your feces. What happens is that this records the esophageal reflux so we can see how bad it is. Another thing that we do is that we send the patient out for an endoscopy, because a long time of esophageal reflux can cause the cells in the lower esophagus, okay? So once again, they can cause a cell in the lower esophagus to undergo metaplasia. In other words, the cells get so constantly disrupted that they turn into an abnormal cell, and that can lead to cancer, okay? So an endoscopy is definitely important in somebody who has had GERD or any other type of reflux. If you necessarily don't think it's a disease, but it's an occasional type of reflux that they have. It can lead to Barrett's esophagus, and this Barrett's esophagus can lead to adenocarcinoma. Okay. Now that we're in the topic of carcinoma, let me go over adenocarcinoma and squamous cell carcinoma. Usually reflux disease will cause Barrett's esophagus on the lower portion of the esophagus, and it can lead to adenocarcinoma. Now, there's another type of common cancer in the esophagus, and it's a squamous cell carcinoma. Now, that's up here in the more proximal portion of the more ascending portion of the esophagus. And squamous cell carcinoma is usually provoked because of alcohol and tobacco intake. So alcohol and tobacco intake provokes squamous cell carcinoma, And esophageal reflux disease provokes Barrett's esophagus, which may lead to adenocarcinoma.